So, am I audible, sir?
Yeah, you are audible.
Okay. So coming to the last presentation of today's, so ultrasound assisted and guided venous access in newborns. So in newborns, we tend to put the umbilical lines, umbilical venous line, umbilical arterial line, and sometimes jugular venous line, and sometimes the PICC line. So how ultrasound can be a measure, because X-ray has got its own fallacies, and maybe the X-ray doesn't tell us the proper position also. So probes and principle, I think from the morning they have been discussed in detail, so I don't need to go about it. But however, I will just let you know that, I will just try to tell you that when you are dealing with the umbilical line, because we want to see whether that line is in heart or not, the phased array probe is good. When you deal with a jugular line, because it is very superficial, so high frequency probe, because the principle is high frequency means it will pick up the superficial structure. Okay, curvilinear is good for the abdomen thing. So these are the types of probe which has been discussed, so I don't want to discuss it more. However, with the linear probe, this is how you see the jugular veins. Okay, so the lateral one, because if this is the lateral side, the lateral one is the vein and the medial one is the artery. So remember that this relationship of jugular vein to carotid artery, the artery is the carotid artery and this is the jugular vein. The relationship is opposite to that of femoral vein and artery. Okay, coming to the umbilical lines. Umbilical vein is the most important one. So when we will talk about the umbilical vein, so first of all, we need to understand the course of the umbilical vein. Okay. So I tell you, when we talk about the course, okay, we can look here. So basically, there are two major veins which are going. One is the inferior vena cava, which is entering into the RA. Now, umbilical vein from the umbilicus has got a separate course. It doesn't enter into the inferior vena cava right away. It enters into the inferior vena cava just before entering into the RA. So where does it go? So umbilical vein goes into the liver, and so it goes, and it connects with the portal sinus, and from the portal sinus to the IVC, that thing is called ductus venosus. Okay, so because ductus venosus is the narrowest part, so many a time the line gets stuck at the testing. So if you look at this picture, so this is the umbilical vein. It starts on, and this is the umbilical recess, or sometimes called the portal sinus also. And here the portal veins are joining. The left portal vein is this one. And then this is ductus venosus. This is ductus venosus. This is DV, ductus venosus. This is portal sinus. And this ductus venosus is entering into the inferior vena cava. This is IVC. This is IVC, and this is RA, right? So see, this is the path of IVC, and this is the path of umbilical vein, right? So many a times, why I am highlighting this is, when umbilical vein has been put in, sometimes in the primitive stage, the doctor is looking for the umbilical venous line in the inferior vena cava. But how can it come in the inferior vena cava? Because it is entering into the inferior vena cava just before the inferior vena cava enters into the right atrium. So we need to understand this, and this course will be very, very important. Now, which line you would suspect or you would look for in inferior vena cava? When you insert a PICC line, peripherally inserted central venous catheter from the leg, that from the leg will follow into the inferior vena cava. That will come in the internal iliac vein and then comes into the inferior vena cava. So for that line, you should scan the inferior vena cava. For the umbilical line, we will tell you that how we should scan for the umbilical line. So this point is very, very clear, very, very important to learn. So umbilical line, where to look for? In the X-ray, we see that this is the diaphragm. It should be just above the diaphragm. Now the lung aeration will vary. You are dealing with a sick baby and baby is having HMD. The diaphragm is here. You give surfactant, the diaphragm moves down. So you don't know what is the optimal position on the X-ray, right? So that is why it is important, because we don't want the lines to be in heart. It is important that we assess it by the ultrasound. Why? Because if the line is in heart, it can lead to pericardial tamponade or effusion. If the line is in the liver, it is lesser down. It can lead to liver necrosis, liver abscess, portal venous thrombosis, or cavernoma formation. So it should neither be down, it should nor be up. The only method is that you put it ultrasound guided. Ultrasound guided means you put it, and then before fixing it, you do the ultrasound and you make sure that the line is there. So people have tried to see that, okay, when people do it, put it like as per the formulas which have been mentioned in the textbooks of neonatology or as per the Shukla formula, so the line is all over the place. Like, okay, so these are, suppose this is total around 60-70 lines. You can say that 18 lines were in left atrium, 13 lines were in 18 lines were in liver, 13 were in the right atrium. So different places the lines are there. So these are the lines which were at the right junction. Right junction is the junction of inferior vena cava to the right atrium. And when they, in this study, when they looked at what is the position on the X-ray, then on the X-ray T8 to T9 is 90% correct and T9 is 100% correct. However, the same findings have not been replicated in the other studies. Like if we look at this study, and this study was done in Calgary only. So if we look at this study, then optimum catheter tip position on US varied T6 to T10 to 11 interspace. Only 44% catheter tips at T9-10 on X-ray were optimum position on the ultrasound. So ultrasound is important. So ultrasound, where to put the probe? So probe should be, if I asked you which side, so this is which shoulder? This is the left shoulder of the baby. So when the pointer is towards the left shoulder of the baby, so this becomes the parasternal short axis view. So parasternal short axis view, see, this is the LA. So this is the RA. So the line comes like this. It is coming like this. Okay, and this is how IVC is coming. So it is coming into the IVC, and if pushed in further, it goes into the LA. So is this a video? Okay, this is the video. See, okay, so this is the line. So this is the line. So if this video is playing, so the center is the aorta, this is the LA, this is the RA, this is the RV, and this is the PA. Okay, so this is how your parasternal short axis is there. So in this view, this is a very good view in which it will tell you whether your line is in heart or not. Because if you see the line tip here, that means it is in the heart, we need to push up. So remember that it doesn't come into the RA, it goes through the RA, but this portion of the RA, and if it is pushed in further, it through the interatrial septum, through the PFO, it enters into the LA. It doesn't go into the RV. Remember that. Sometimes while seeing on the X-ray also, when the line is too deep, we say that, oh, the line is in RV. No, it's not in the RV. It goes this way and it goes into the L. So the course is very important. So inferior vena cava is coming like this way, and the line, your umbilical line which you are putting is coming this way, and it is entering into the inferior vena cava just before the IVC enters into the RA. And this is the place where we want the line to be there. Okay, so I will play the video again. Okay, next slide. I think I have one more video. I will go for the pen setting and now. Okay, so can we play the video? Okay, so where is the line now? So line is here in the liver. So in this picture, so here will be RA, which is not in the picture. This must be the inferior vena cava. The line was coming like this, but because there was some resistance here, and this is the place where people, when you are putting the lines, you also must be saying that sometimes you cannot extend the line beyond, and when you extend the line beyond, then the blood stops coming. When you pull the line, at one point the blood starts coming. So why? because this is the narrow portion, this is the portal sinus, and this is the ductus venosus. This is ductus venosus, this is the portal sinus, and here the line gets stuck, and sometime if you advance it further, it may leave the way. It may go to the left portal vein or the right portal vein. That is why the blood doesn't come, right? And when you pull it out, when you come in the portal sinus, the blood starts coming. Okay, so it's important that sometimes on the X-ray you will just see that the line is in liver territory, but on the ultrasound you can come to know that okay, where the line actually is. So you can see that the line tip is, you can see that the line tip is located here in this. Okay. Now, this is what I was trying to tell you. So when the line is coming, so basically this is inferior vena cava. This is IVC. This is right atrium. So this is the hepatic vein. HV is hepatic vein. So umbilical line is coming from here, and then it rests into the pulmonary, in the portal sinus, and from the portal sinus, ductus venosus, and then in the IVC. So we don't want line here. We don't want line here. We don't want line here. So this becomes the optimal place. And there is only one way by which the line can be in this place, and that is by the help of the ultrasound. Also, many a time the M mode is handy. Like I know that this is the line, but if you have a confusion, you put the M mode, and then you can see that in the M mode, this is the line. Okay. And sometime always remember, if the line is too deep in the heart, even in the apical view, you will see that the tip is lying in the LA. So this was for the umbilical vein. We will be seeing few cases or few videos later on for the umbilical artery. For the artery, it is in the aorta and it enters into the, so basically umbilical artery, it goes first downwards and then it enters into the aorta and it goes like this. Okay. We understand that on X-ray, the T6 to T9 is a good position, which is a upper position, and L3 to L5 is the low-lying position. It should not be in this area because this is the territory where the celiac and SMA supply or renal artery is there. If the line tip is in this place, these organs, the blood supply can be hampered. So high placement is better than the low placement. However, if by chance your line is in this area, never advance it because it has become unsterile after you have done the X-ray. You always remove it and bring it to the low placement area. The formulas are good for it, but if you want to avoid the X-ray, you very easy. So remember, so which is the sign? How do you see for the IVC and the aorta? So subcostal view, right? Longitudinal view, your marker is pointing towards the head of the baby, 12 o'clock position. And you do a right leftward tilt. So tilting towards the left side. Your tail is going this way, right way, and the camera is going towards the left because aorta is left and IVC is right. If I have to scan the IVC, I will go the other way around, the right way around. So this is the nice view which Dr. Murthy showed initially. So the aorta, and aorta is lying against the spine. So this is the spine. So aorta, and from the aorta, the fork-like two vessels which are arising, right? And these are the SMA and the celiac. Okay, right? So how does ultrasound help us? We just need to know that our UAC tip is crossing this. If they have crossed the territory of these lines, the superior mesenteric artery and the celiac, so that means it is high up. We don't need to worry about it. So in this case, if you see, this is the SMA, this is the celiac, right? And the line tip is crossing it. It may be going here also. I cannot estimate why, because after some time, the accurate position, it is not able to, we cannot able to scan because the beam may not be so much perpendicular to the line. So in 2D mode, it's difficult to scan, but always we can see that whether the line has passed that or not. And if the line is lower down, you can scan that area. You can follow that. So this is a case in which on X-ray, The UVC tip is just above the diaphragm. So everybody will say that, okay, it is the right place. We don't need to do anything. But we do the echo, and on the echo, you can see that the tip is lying in the LA. So we need to pull it out. We need to bring it here. So we need to on the ultrasound, we need to calculate this much distance and pull it out, because this is the, again, I'm revising the view. This is the aorta, the RV, the RA, the LA, and the septum. And you can see that the line is just entering into the LA, and this is the pulmonary artery. On the UVC was okay. So you can see that this is the aorta, and this is the line, the SMA, which is arising, and the tip is at least crossing the SMA. It may be going a little bit down. So it strips the crossing of SMA and celiac, but we can't trace it to T6, because if we believe that they arise at T12, then this vertebra will be T11 or T10. T6 will be somewhere here, but we are not able to trace it. Many people from the suprasternal view, when they see the descending aorta, they try to see the tip of the vessel. If you are doing only X-ray, so sometimes the X-ray is cut from below, you don't know whether it's a UVC or UAC. Lateral view does help us. So the UAC, because aorta is lying next to the spine, so this is the spine, so it goes like this. And UVC, as I was telling you, the course is different. This is the skin, it is entering the skin, going portal sinus, then ductus venosus, and then entering into the IVC. Okay, so lateral sometimes it's very, very handy. Okay, another case, you can see that the line tip is, the UVC tip is here, and this is a near perfect place. So sometimes you don't get an excellent view or best view, because you have to angulate. So this is aorta, this is LA, here it will be RA. So the line is almost near at the perfect tip. So for the umbilical arterial line, again crossing. So sometimes linear probe can also help. So you can see that this red color is the SMA, and you can see that this is a line very clearly, and the line is crossing this thing. So in this case, the UVC tip is here. We don't know whether it's in the proper place or not. I do not know how people will interpret it. It's shown at T10. So in many studies, T10 was the right place, but your ultrasound will be a good place. You see that in the ultrasound, the tip was in the portal sinus. So it's not in a right place. We need to pull it down. So in this, it is above the diaphragm. So it may be proper, it may not be proper. Let's see, what do we look? Oh, this is not playing, but the tip is almost at the right place. It's at the before. This is the heart, before entering into the heart at the IVCRA junction. And the UAC is okay. So in this, again, this is lower down T11, and there you can see that it's in the portal sinus. So see very clearly it's mentioned, this is the portal sinus, this is the ductus venosus, this is the inferior vena cava, and this is the hepatic vein, and this is the right atrium. So this confluence is there, this is IVC, and one ductus venosus is entering through umbilical artery, umbilical vein, and then ductus venosus, one hepatic vein. So after ductus venosus, this is the point where normally we say that the UVC tip should be there. So this is under ultrasound guidance. If we see that, I will try to obstruct the video. Okay. You can see that this is the line. Okay. So when you are doing it under ultrasound guidance, your field is sterile. You are not checking it afterwards. So person has pushed it, and now you can see that he will keep on withdrawing, and he will leave it here. So this is, we have anticipated that this is the best way, and that under ultrasound guidance you will put, and this was the X-ray when the line was left at the proper place. Okay, so this was for the umbilical lines. For in nutshell, umbilical venous line, the ultrasound is very good. For the umbilical arterial line, you can just get an idea whether it is passing beyond the SMA and celiac, and that will serve your purpose. And we can surely say that if after doing 50 or 100 ultrasound, if you are confident, you can stop doing X-ray just to check for the umbilical, venous line or arterial line. Don't start doing it after doing the scan workshop, but first let it do in the 50-100 babies. Screen them through some of us, so that you come to know that, okay, whatever you are doing right, and then you can omit doing that. Now, another thing is, sometimes you encounter a baby and all the veins have pricked. There is no place for a prick line. Baby is 20 days old and you can't put the umbilical line also. So now which central line to put? Many a times we used to put the femoral line, but that was a blinded procedure. The jugular vein, now we have started putting it. It's very, very easy to put. Not as easy as it is sounding, but however, under ultrasound guidance, it can be put. There will be a station on the blue phantom where you will be tracking the needle, and Sumesh will be taking that station. So for the purpose of presentation, how do we differentiate between the vein and the artery? So because the image I will be showing you, you will be seeing two circles. So how to differentiate which one is vein, which one is artery? One is by the location. For the vein is lateral and artery is medial. The another very, very important finding is, you just give a little bit of pressure, and you will see that the vein is collapsing, vein is compressing, but the artery is not compressing because artery has got a thick wall. Rest flow dynamics are also there, but many a times you can do it, many a times you don't do it, because in the vein there is a constant flow, in the artery there will be a pulsatile flow. If you put the pulse wave Doppler. So this is the picture which you normally see. IJV, it is lateral and artery is medial. Okay, this is the sternocleidomastoid muscle. So there are two ways of scanning it. So is there a dummy? Okay, I will show you here. So baby is lying and this is the neck. So when our probe is in this direction, the vessels are in this direction. So this is a transverse section or the short axis view. Okay, and this is a longitudinal section which is along the line, along the direction. I hope it is clear that in the neck, the vessels are going in this direction. When our probe is in this direction, that is the longitudinal view. And when the probe is cutting the lines, because the lines are going in this direction, this is the short axis view. Now in adults, they normally put it in this direction, because in this direction, it is very, very easy for you to track the needle. And on Tuesday also, once you will be practicing, you will be practicing in this direction, in both the directions, but you will see that this direction is a very, very nice direction. The problem in newborn is that the newborn neck is very small, and this hockey stick probe has got approximately 2.5 centimeter length. So many a time it's not possible. So in newborn, majority of us, they put it in the short axis view. So in short axis view, how do they appear? See, this is the lateral side and this is the medial side. That you have to be ensured, because in the linear probes, many a times the probe marker is on this side. You will understand it once you start using it. So on the lateral side, if you see, then when I'm pressing it, it is compressing. This vessel is the compressible vessel, and this vessel is not the compressible vessel. So this is the vein and this is the artery. This is the artery and this is the vein. So that's how you sense it. Here you can see in the longitudinal way, there are two vessels which are appearing. If I will stop it only, then I can show you. Okay, so this stiff vessel is the carotid artery. When I move further, you see that this vessel goes and this compressible thing arises. This is the vein. Okay, so in longitudinal, they will be placed side to side. They will be placed side to side. So here, because I have to see them, put them in one video frame, I slide my probe. So if you don't slide your probe, just locate the compressible vessel. Remember at this point is, it's not that they are always lateral and medial. Sometimes they are superior and inferior also. So that is why compressibility test is the best test. So this is what we were trying to tell you is, when in the short, along the in the short axis view, like in the newborns, how we are putting it. So sometime if you are putting the needle, you are visualizing the needle, but only at this point this is in the right place. Here also you are visualizing, here also. So in longitudinal plane, in this plane, it is easier to track the needle. However, in this plane, it's not so easier. Tracking is easier, but every time just to make sure that the needle is in vein, sometimes it's not, it's little tricky. But this is the only way in the newborn by which we can put. So like this was the baby when we were putting. This is the subcostal view. You can see, okay, this video is not playing. This is, so you can see the needle going. So this is the vein, and you can see that this is the tip of the needle which is going and which is pricking you, right? And this is the artery. Be away from the artery. Then you took the transducer out, and you, whichever way, Seldinger way or whichever way, you can put the line. And if you want to do an X-ray, you do an X-ray. But even if we put the shortest 4 centimeter line, many a time it is in the RA. Why? Because the length from the neck to the RA is very, very short. There is another approach, because longitudinal approach in the neck is not possible. So this is called the supraclavicular approach, where the brachiocephalic vein is being cannulated. So, so basically our probe is above the, so suppose this is the clavicle, the probe is above the clavicle, and we tend to angulate it in the longitudinal way, because in the longitudinal way, once we go in this direction, so then we can track the needle better. So this is the supraclavicular brachiocephalic approach, and many people use it. We have now started using it. Right now, a mixed approach is there, mixed response is there, but let's see. So I think for the PICC line, it's not so difficult. From the leg, when we put the PICC line, from the leg, the tip should be in the IVC. It should not be in the RA. And from the arm, when we put, it should be in the SVC, and it should not be in the RA. Okay. Okay, so for superior vena cava view, I was telling you that I will tell you the view on that day. So basically, in the IVC, this is a good place. This is the hepatic vein, and this is the RA. So we don't want the line to be here. This is a good place. Similarly, SVC. So let me show. Okay, so this was the line which was put from the arm. Obviously, the line is quite deep, right? But here you can see that this is the superior vena cava. It is going into the RA. So we can take it out. So this was the PICC line. You can see that how the line is going. So, and remember that the PICC line goes in this direction from RA to the RV. And on the X-ray also, this is an invertogram. You can see that I can trace it from here till here. So sometime if it is in the neck, we can trace it. It was going up. So with the linear probe, it's very easy. If it's not in the heart, you can trace it. So for umbilical venous line, I will say ultrasound is very good. For UAC, X-ray is accurate, but there is no need if you can say that, okay, it's crossing. For PICC line, ultrasound is definitely better. And for IJV, if we have to put, we can put it ultrasound guided. Thank you very much, and I'm quite open to take the questions, and I think you all must be waiting for the World Cup final also, and for the India to take the cup after 12 years. So where is my Zoom? Stop share. Okay, many participants have already left actually.
Yeah.
Okay, okay. Any questions? I think for the last talk, there are not much of the questions.
Yeah.
Anybody, any questions?
Any questions, they can keep it so that during the hands-on session,
Yeah.
anyway, we do the recap. So it might be a little more easier to answer when we are physically present there.
Sure.
Exhaustive, and you took a lot of pain, Dr. Naveen. Thank you so much.
No, sir, same with you. You have done so much of the work, and I think it was an awesome this thing. And next time onwards, I think this 2-day at least should be a good this thing, that we can do the presentations earlier, and then so that they get a lot of hands-on.
Correct.
And thank you all the delegates. Thank you, sir. Thank you, Sumesh. thank you to all the faculty. I saw that Dr. Anita is there from the start.